Hello, welcome to today's first ever Vasculitis Women's Conference. I'm Joyce Coleman, and I'm the Executive Director of the Vasculitis Foundation. Thank you for joining us today. It is wonderful to have so many participants ready to connect and learn from our incredible speakers and from each other. Our goal for today is to develop a greater understanding of how vasculitis impacts women in all aspects of life and to build upon the collective strength of our community through education and connection with other patients living with vasculitis. This conference was recorded live on June 12, 2021. We have edited the 5 sessions into individual webinars and encourage you to watch all of them as you have time. Each session is unique and all of the speakers share important knowledge and expertise. My co-host for today's conference is Kaylin Young, the Director of Development and Communications with the Vasculitis Foundation. Kaylin has her master's degree in social justice and human rights, specializing in qualitative research methodologies. She served as the Director of Research Affairs for the Vasculitis Patient-Powered Research Network, our VPPRN, for the 7 years prior to May 2021. Kaylin has dedicated her career to patient engagement in clinical research and has a deep passion for elevating the patient voice in research design, implementation, and development. Also joining us today on the conference and working in the background is Ed Becker, our VF media producer. Ed produces the VF Road to Wellness webinar series and the Vasculitis Visionary podcast, featuring conversations with medical specialists from around the world. He also serves as co-producer on a new podcast series, the ACR VF Guidelines, which will be launched later this summer. And we want to especially thank our sponsors, Amgen, Genentech, and GSK, for their support of our 2021 Patient Virtual Conference Series. Thank you. The title of today's session is Bad to the Bone, Bone Health for Women, and our speaker is Dr. Julie McGregor. Dr. McGregor is a board-certified internist and nephrologist trained in integrative medicine and is one of the co-founders of the Integrative Medical Clinic of North Carolina. Dr. McGregor hails from the University of North Carolina at Chapel Hill, where she worked in the hospital for 12 years, including a vasculitis fellowship at UNC Kidney Center, and was on the faculty at UNC School of Medicine for 5 years. Dr. McGregor, thank you so much for being with us today.
Thank you so much for having me. We're going to talk about bones and vasculitis, and most importantly, women. So I'd like to acknowledge the Vasculitis Foundation. What a wonderful organization. And thank you so much to Joyce and Kaylin for inviting me to speak. Thank you also for focusing on women's health. It's a really underserved focus as of today. And I'm so glad that you all are trying to look at how women are going to try to stay healthy and to get healthy, and the specifics about the female biology with respect to illness and disease and health. So thank you for this. So Kaylin specifically asked me to answer 5 questions that had come from the Vasculitis Foundation patient group, which were, does vasculitis impact my bone health? Or is it just the medications that impact the bone health? What can I do to help prevent bone loss? Or is bone loss basically a losing battle? Also, if medication causes bone deterioration, is it permanent? Are women more at risk than men when it comes to bone health? And people say your diet helps prevent bone loss. Is that true? So I'm going to start with some background slides and then get to the questions that were presented from the patients. So steroids do increase the risk of developing osteoporosis. And that's something that most of us as providers and patients really do know is true. Postmenopausal women who take steroids for longer than 6 months have the greatest risk of bone loss. but anyone who's taking steroids will have the risk of osteoporosis. Bone loss occurs most rapidly in the first 6 months of starting with steroids. And after 12 months, there's still the loss of bone, but that seems to slow down. In people who are using inhaled steroids, there is less of a problem, although it's not zero for getting osteoporosis. And people who use topical steroids are much less likely to have osteoporosis as an adverse event from the steroids. The major impact of steroids on bone, besides avascular necrosis, which is not really our topic for today, would be fractures of spine and ribs. So less likely to have the hip fractures and more likely to have vertebral fractures and rib fractures. Steroid doses of 5 milligrams of prednisone or the equivalent of 5 milligrams of prednisone daily, taken for more than 3 months, will cause a risk for fracture. And the risks will increase as the daily dose of steroids increase. Almost 1 in 3 postmenopausal women who routinely take steroids will end up with a spine fracture. And that may not be specifically from an injury. A person on steroids is more than twice as likely to have a spine fracture compared to a person who's not taking steroids. So again, this is kind of the background to the questions that you all have asked, but I did think it was important for us to have that information. How do we find out about a person's bone health? Usually we use a DEXA scan, and the DEXA scan will define for your providers your risk of fracture and how strong the bones are. So the definition of osteoporosis is decided by the radiologist giving a score to how dense the bone is through these DEXA scans. And osteoporosis is a diagnosis of a T-score, which is a density score of less than or equal to negative 2.5. There are people who are not with normal bones and not osteoporotic that have osteopenia or kind of have a high risk to osteoporosis. And that's defined as a bone density score or a T-score of -1 to -2.5. The radiologist will also use these DEXA scans to make a prediction based on the density of the bones and if they have some clinical information available from your provider about something they call a FRAX score, which is a 10-year probability of a hip fracture or a major osteoporotic fracture of greater than 20%, or this probability score of greater than or equal to 3. So again, this is just trying to say, you know, what do we use to define osteoporosis? And how do we gauge how severe the bone illness can be? So there are a number of medications that people will use for osteoporosis, and the decision on whether a person needs medications and what kind of medication is used should be made in partnership between the provider and the patient. And there are some things like the ability to swallow well and esophageal illness, chronic kidney disease, multiple different considerations that will help decide if you need an agent and what agent is the right one to use. So osteoporosis is problematic primarily if a person falls, because fracture affects quality of life and also will affect longevity of life. And so the major concern around bone health really lies in how do we prevent fracture? Thus, how do we prevent injury? There's not a requirement for falling or injury for a fracture to ensue. Sometimes people will have just spontaneous fractures if the bones are very fragile. And so if a person has had what they call fragility fractures, which are compression fractures of the vertebral spine or kind of a collapse of the bones in the back without specific injury sometimes, or if a person has a very severe T-score, or if the DEXA scan says that the bones are not very dense, or if a person has a comorbidity such as vasculitis or stroke or Parkinson's disease or diabetes, the risk of fracture can increase. I've listed a number of risks for falling because it's very important for us to remember with respect to bone health. Are we doing everything that we can to keep ourselves safe? So the risks for falling include people who are of advanced age, people who have had previous falls, anyone who feels weak or has difficulty with gait and balance. You know, many of these things I think have come up already today as being really important considerations with vasculitis, including poor vision and sometimes low blood pressure, which can be a part of the disease process or could be medication induced. Another risk for falling are people who are afraid of falling. There are a lot of environmental things to consider with respect to falls and trying to prevent falls, including homes that don't have stair handrails, poor stair design, if the bathtub or the shower doesn't have a bar for holding on to prevent falls, if there's dim lighting, or if the home or the environment that a person's in has obstacles or tripping hazards, any slippery surfaces or uneven surfaces, medication side effects, and then if people are immobilized and are requiring assistance for ambulation, for walking, if the devices aren't being used carefully, there can be a risk for falling. So a lot of this consideration has specific implications in the vasculitis world. And so it is really important for us to remember that when we're thinking about osteoporosis, it is really important to remember not only the bones, but also how stable we are, how strong we feel, and how safe the environment is that we're living in and working in and visiting. So getting to the specific questions with that as a background, the question that came up first was, does vasculitis impact my bone health, or is it just the medications? So it's a really great question that doesn't have research-driven answers yet. I would say that probably the answer is yes, that vasculitis will in and of itself affect bone health. At the root of all disease really is inflammation, and vasculitis is a disease of inflammation, and it affects the entire body. It's a systemic process. So we do know that damaged vessels, which will occur with vasculitis, will require eventually calcium to help to repair. And a lot of times when the body needs calcium, it's going to get it from the bones. And so as many blood vessels are undergoing inflammatory changes, it may be that we are draining our bones somewhat in order to repair those blood vessels. Again, this is not paper or research. This is just information about how the body works. So I would say that if you were taking a test, the answer is that right now we don't have proof that vasculitis itself causes osteoporosis, but there is likely many factors that go into how strong the bones are. And if one has an inflammatory process going on in the body and has vasculitis, it's likely affecting the bone health. The next question, what can I do to help prevent bone loss, or is this a losing battle? So there are many things that we can do to try to help to keep the bones strong, but we have to do it in a safe way, which is why having the background about risks for fracture was an important step to take. One of the things we really do talk about with respect to osteoporosis prevention is exercise and weight-bearing exercise. Even now they're talking about non-weight-bearing exercise potentially impacting outcomes with osteoporosis. But it's very good for the bones to be strained, meaning that there are signals that are in our brain that when the brain is told that there's pressure in the body, the brain sends signals to the bone to say, bone, you need to build so that we can handle the stressors coming at us. And so it's very important to stress and strain the body so that the bones will be triggered to strengthen. Other things that can try to help prevent thinning of the bones are reducing alcohol consumption and stopping smoking. There are other maybe less proven and potentially more controversial but interesting products out there. I show on the slide here a woman on a vibration plate, but there are ideas around ways in which the bone building mechanisms in the body and feedback loops could be triggered through devices. Again, it's really important to remember safety when you're using anything like a vibration plate or exercising. And if you have questions with your body and having vasculitis and the impacts of the medications on your body and the vasculitis on your body, and how exercise or using any devices may impact you, it's important to get some advice from a physical therapist or a trainer or your provider before embarking on anything that might lead to a fall. It's also really interesting to think through hormone replacement therapy. I would say our first speaker today talked about hormone replacement therapy as an important therapeutic consideration with respect to early menopause and the use of cyclophosphamide. I think hormone replacement therapy is also an important consideration with respect to osteoporosis prevention. We have information that if a female chooses to start estrogen therapy when perimenopausal or in the early stages of menopause, bone health is, or bone density is stronger, even if that person ends up discontinuing the hormone replacement therapy at the age of 65. So use of hormone replacement therapy is going to have long-term implications, even if it isn't continued. I do have women who ask me, I didn't do hormone replacement therapy in my 30s, 40s, or 50s. Can I start it in my 60s? There are many providers who say that you should not do that, but there are potentially studies coming out showing that potentially it's not dangerous to start hormone replacement therapy later. And you just need to speak with your providers and find people who'd be willing to talk to you and listen to you about hormone replacement therapy if that's something that you'd be interested in. Of course, it's somewhat of a controversial topic because many women have heard that there are great risks to hormone replacement therapy. Primarily, people worry about clotting. And in vasculitis, there's also a risk of clotting in and of itself, just having vasculitis. There's a concern about breast cancer and other estrogen or progesterone related cancers like ovarian, uterine. So we know that long-term immunosuppression can also put us at risk of cancer. And so we have to be really careful with assessing whether or not an intervention has the right risk to benefit ratio. But, just piggybacking on what we've already heard today, there's a lot of potential benefits that can come with estrogen. Many women have less aches, less pain, less difficulty with vaginal dryness and pain with intercourse, and certainly less osteoporosis. So it is something to consider, but needs to be something discussed with your providers. And if you feel like your providers don't have the full picture, continuing, like Dr. Gordon had said, keep pushing until you find somebody who can talk with you about your concerns and what you would like to achieve for your goals for quality of life. I can say for many women, the quality of life does improve with hormone replacement therapy, but not all. So that's probably enough on that. Going from one relatively controversial topic to another, I have no affiliation with this organization, but there are organizations, this one included, that have really interesting what they would call biohacks around how to help build bone. This particular organization is a nationwide chain, and they have data that they've provided that shows that one can do about, I think it's 10 to 15 minutes a week of straining the bone with maximal force in 4 different directions using these machines shown on the slide here. And that holding, I believe it's 30 seconds or something in that arena, a maximal force once a week can help bring increased strength to the bones. So again, I just provide this, not all providers that you're working with may know or agree with some of the things that are out there, but I provide this as sort of a backdrop of there's a lot of investigations going into what we can do to help prevent osteoporosis and treat osteoporosis. And so there's definitely, it's not a losing battle. Never give up, please, even if a person's had a fracture or has severe osteoporosis, there's lots of options for treatment out there. The next question was, if a medication causes bone deterioration, is it permanent? So particularly with steroids, we know that several studies show that osteoporosis is reversible and improves after you stop the steroid therapy. Are women more at risk than men when it comes to bone health? Yes. So that is true both in patients who have been using prednisone and in women and men who are otherwise disease-free. So all females are at greater risk than males for osteoporosis. And then both men and women who receive corticosteroids are at risk for osteoporosis, and women who have steroids are at greater risk than men who have steroids for osteoporosis. So the specific statistics show that 1 in 2 women will have an osteoporotic fracture, whereas only 1 in 5 men will have an osteoporotic fracture while on steroids. So there is a gender difference. The reasoning is likely because female hormone dynamics shift sooner than men. We do have sort of this emerging concept of andropause and the decrease of testosterone for men that likely affects their bone health, but certainly menopause, especially if it's early menopause related to therapy or disease process, will reduce the bone protective hormones in women sooner than men. People say your diet helps prevent bone loss. Is that true? And yes, absolutely. Diet really can affect bone loss. And this is a way in which we can be proactive with respect to helping to heal our bones. There is a thought that diets that are high in phosphorus can cause calcium to be pulled from bones. And so one potential way in which a person can use food as medicine to slow bone loss is to try to limit high phosphorus foods. And I have some of these pictured here: meat, poultry, fish, nuts, beans and lentils, dairy, bran, grains, sodas, iced tea. These are not all bad foods necessarily, but just sort of things to consider with respect to bone health and how calcium will be affected by what we eat. Another consideration are high acid foods also stimulate the loss of calcium from bones. And so one could choose to do a more alkaline diet, which just in general is a more fruits and vegetables type diet as a way of helping to preserve bone health. Building bone matrix requires a lot of minerals, including boron, strontium, calcium, and then lots of vitamins, including vitamin D and the B vitamins. There's a desire to really avoid malnutrition. And although that sounds obvious, it's very complicated when a person has vasculitis and autoimmune disease, because many of the medications that are used for treating autoimmunity can affect absorption in the GI tract. There's also a lot of thought that autoimmune disease has its roots in gut health. And if a person has problems with the right dynamic, the right microbiome, the right kind of milieu that's in the intestines, if there's a problem with that, or if there's decreased capacity to make digestive enzymes, which will either happen as a result of medications or as a result of chronic illness, then it's difficult to absorb the food that we're eating. So even in a very well-intentioned person who's putting really good things in the mouth, if you can't get the nutrients that you're swallowing absorbed into the bloodstream, then it's not going to get into the bones. And so malnutrition is a consideration with respect to bone health, especially in chronic illness. And the maybe obvious one is calcium. So calcium is an important consideration for bone health. And it's been somewhat controversial whether or not we should be using calcium supplements. Right now, guidelines say that we need to think about having 1,200 milligrams of calcium per day, either through the foods we're eating or with supplementation. And eating foods that are high in calcium may allow for being able to avoid specific calcium supplementation. But vitamin D is a very important part of this story because vitamin D actually helps to absorb the calcium. And so if a person is vitamin D deficient, which is very much the case for many who do not supplement with vitamin D, then it will leave the body unable to absorb calcium, even if calcium is being taken in through the diet and with or without supplementation. So vitamin D can like eggs and milk and salmon and other oily fish, but almost all of us, with or without vasculitis, need to be on a vitamin D supplementation, especially if you're taking steroids. So if a person wanted to be really specific about getting the 1,200 milligrams of calcium in through the diet, there are many sources out on the internet that can give you how much calcium is in the food that you're eating. And trying to count up and get enough calcium every day is a great way of being proactive with respect to bone health. So to answer your questions, just in conclusion slide, vasculitis likely does affect bone health, but there isn't a lot of research out there to show that. But it is definitely, osteoporosis is definitely related to the medications that a person with vasculitis may be prescribed. Preventing bone loss is never a losing battle, and there's lots of options out there. And I do encourage you, as the previous speaker did, to never give up. Usually steroid-induced osteoporosis is reversible, so it's not permanent. Women are more at risk than men when it comes to bone health. And you absolutely can be proactive with respect to your diet for helping to prevent bone loss. So thank you so much for allowing me to speak on this wonderful, momentous women's conference for the Vasculitis Foundation. Thank you.
Dr. McGregor, thank you so much for speaking today. We have just a few questions. One of them was, so which doctor do you talk to about hormone replacement? Is that the rheumatologist, the nephrologist, the OBGYN? Help us out here. Yeah, it's a wonderful question.
So, you know, I think that gynecologists probably are the specialty in medicine who are most familiar with it. There may be other providers on your team who feel comfortable with this, but my guess is this is probably going to be a gynecology question.
Okay, great. Thank you. So do you recommend patients, newly diagnosed patients, or even patients who've been around, do you recommend that they get a baseline to see how they're doing with bone health?
So I think it's a very good idea because with respect to the impact of steroids, if you already have bone loss, osteopenia, or osteoporosis, it would be important to get proactive with bone health, maybe even in a more assertive way. than if one has normal bone at the initiation of therapy.
Okay. And another question that came in via email, should you take your vitamin D supplement at the same time as you're having breakfast, or does it need to be taken a different time away from, like, if you take steroids in the morning?
Great question. So traditionally, vitamin D should be taken with a fat in the diet. So some sort of meal that has fat, because it's a fat soluble vitamin. It is better to take it in the morning or middle of the day because it can impact sleep. So if you take vitamin D too close to the evening, that may cause insomnia. But with respect to taking it around steroids, I don't know of any reason to specifically time it away from your steroids.
Okay. And another question that came in, vitamin D2 or vitamin D3?
Yeah, it's a great question. I think the vitamin D3 is probably the easiest for most of us to access, just over the counter. And vitamin D2 is more of a prescription once or twice a week, 50,000 international units. My preference is D3 actually with respect to physiology, but some people need to have the prescription D2, 50,000 international units. And if your provider deems that appropriate, that's reasonable.
Okay, great. And Judith put a comment in the chat window about she works with an endocrinologist for her bone health, and she takes Fosamax as a preventative maintenance, but that's another doctor that, another specialist that patients can add to their team.
Mm-hmm. Yeah, absolutely. I would say endocrinology maybe also, and it may have been in response to the question about hormone replacement therapy. Some endocrinologists are really comfortable with doing hormone replacement therapy as well as the bisphosphonates and other osteoporosis medications. So yeah, just, poke around with your providers and find out what they are interested in and feel comfortable with and can talk with you about.
Okay, great. Thank you. The last question is, I'm facing spine and knee surgery. What are my special considerations? I'm not on steroids, only a IgE blocker, biologic. How dangerous with vasculitis? And you may not be able to comment direct, just generally, possibly.
And if I'm understanding correctly, I would just think with respect to if the question's on how to protect the bones and to be healthy with the bones around surgery, orthopedic surgeries, I would say probably just working with the physical therapist to be as, active as you can be post-operatively would be good so that you don't end up laying around post-operatively too long and getting deconditioned. And then around just staying as well nourished as you can. Sometimes around surgery, it can become complicated to eat well and stay with the right nutrients in the body. So, but other than that, I just wish you well.
Great. Thank you again, Dr. McGregor, for spending your afternoon with us. We really appreciate it. Have a great afternoon. We also encourage everyone to watch the other 4 recorded sessions from today's conference. And we want to especially thank our sponsors, Amgen, Genentech, and GSK, for their support of our 2021 Patient Virtual Conference Series. Thank you again for joining us today.